happen, gingival inflammation will takes place. Gingival inflammation is nothing but gingivitis. Okay, in that again we have stages of the gingivitis: initial, early, ಶ್ರುತಿ ಅವರ ಟೀ ಕುಡಿಯೋಕೆ ಹೋಗಿದ್ದಾರೆ. ಹೌದಾ, ಹೇಳಿ, ಟೀ ಕುಡಿಯೋಕೆ ಹೋಗಿದ್ದಾರೆ, ಫೋನ್ ಮಾಡೋಕ್ಕೆ ಹೇಳಿ. So in like when the inflammation is in the early stages, that means like initial or early stages, that will be called as gingivitis. When it is going towards the established stage, then that means like it's like periodontally it's involved. Okay, from the inflammation of the gingiva, it's involved in the periodontal fibers also. Okay, when it is in the advanced stage, that means it's a fully periodontitis. After that, what will happen? Pocket deepening will takes place. Once the pocket deepening will takes place, and again we are not treated that patient, means what what will happen? Plaque accumulation. It's a like circle. If you doesn't treat this pocket, again plaque accumulation will be more in the pocket, and again it causes gingival inflammation. Again
pocket
deepening of the pocket will takes place. So what are the like as I told you, like there are two treatment modalities. One is non-surgical therapy and one is surgical therapy. When like at a critical probing depth, that is called 5 mm probing depth, pocket probing. Okay, if the pocket probing depth is less than 5 mm, you can go ahead with scaling, root planing, curettage, along with local drug delivery and photodynamic therapy, laser therapies and all. Those are called as non-surgical therapies. And antibiotic therapy also. If the pocket depth is more than 5 mm, then you are supposed to go ahead with surgical therapy. Okay, that is nothing but flap surgery and all. So sometimes even though pocket depth is more than 5 mm, we'll go ahead with non-surgical therapy. Why? Because patient might be having medically compromised, patient might be diabetic, okay, he might be having some other medical issues, or sometimes what happens like already we have done surgical treatment in that year, so again and again we can't do the surgical treatment repeatedly. In such cases, it like what we do is like supportive periodontal therapy by using non-surgical therapy.
After 6 months,
yes.
7 months.
So when we do the non-surgical therapy, what will happen? It will arrest the disease progression for 6 to 8 months. So we can do. That's the reason every 6 months once you are supposed to call for follow-up. After like a periodontal therapy, you are supposed to call after 3 months once. First visit is like after 1 month. After that 3 months, then you're supposed to call it after every 6 months. Every 6 months once perio like problem is there, means every 6 months once without fail they are supposed to get a cleaning done. Then only like your treatment is going to be successful. Okay. So what are the like so now just imagine you have done like scaling, root planing, basic therapy. Still that also pocket has not reduced. So that time what you can do is like you can go ahead with periodontal therapy. Flap surgery. So why we do? To eliminate pathological changes in the pocket walls and to create stable, easily maintainable state, and if possible to promote periodontal regeneration. We have two different types. After any treatment, either it should get repaired or regenerate. Okay, every time regeneration is not possible. Only repair will take place. Okay, so when like we get a regeneration, it's very good. Repair is nothing but reattachment. Perio is all about the junctional epithelium. You remember, no? Junctional epithelium is the epithelium which connects the gingiva to the tooth surface. That is very important. If that is not there, then what will happen? Pocket formation. Junction is not there, so obviously it's open. This is a different entity. Gum is different entity. Root is different entity. So center mein gap will be there. Correct? So junction epithelium is very important. So sometimes what happens, during like any other procedures we may get repair. Okay, very few times we'll get a regeneration. Repair is nothing but reattachment. Whatever the tissue was there, damaged tissue was there, after the therapy the same thing will reattach there.
7 days the
epithelial cells migrate to there, so they will do it, their work. So if the epithelial cells come into the picture, because within 7 days it will come. So what will happen? Long junctional epithelium will take place.
Long junction.
Okay. So actually we have 4 different types of cells. One is epithelial cells, one is connective tissue cells, one more is alveolar bone cells, and one more is periodontal cells. These are the 4 cells. Before and all, we didn't know that which cells are the responsible for the regeneration. Okay, regeneration of the periodontal ligament. They were not knowing that. So what happened, like they kept doing the every treatment. So later on, like by doing single cells, they have like initiated to grow there. Then later on, they understood if the PDL cells are present, then only regeneration will take place.
Long junction epithelium and junction epithelium is same?
No. Long junction epithelium and junction epithelium are both are different.
तेरा जैसे देखिए ना वैसे ही वो बना हुआ है इसके अलावा इस पे देखिए यूट्यूब का बना हुआ है फोल्डर बना हुआ है ना वैसे ही ईमेल का बना हुआ है मेल लिखा था
See, so they were in a so confusion what cells are like giving rise to the regeneration. So the concept has come by like Mechler's hypothesis. He gave the concept that to get a new connective tissue attachment, that is called as regeneration, PDL cells has to come into the picture. Can you see this? This is epithelial cells, this is connective tissue cells, this is alveolar bone cells, and this is the PDL cells, this is cementum, this is tooth. So root surface, so cementum. Okay. So they tried with this. Why? Because is this epithelial cells start like forming from the third day only, correct? Epithelial cells migrate to the like where the injury is there, it will migrate to there within third day. Okay, by 7th day it will complete the formation of epithelial layer. Any like wound, just imagine within 7 days you can see the closure. Only epithelial layer. Okay, so if the epithelial cells come into the location where you have done any procedure, so what will happen? This is how long junctional epithelium takes place. If this taken place means junctional epithelium is normal junction. Okay, it's like this. If can you see the difference here? It is like this, and it is long junctional epithelium. It will be very weak. Okay, because only epithelial cells are formed, no connective tissue formed there. So that's the reason, like if you put more pressure or by probing also, what will happen? You will damage this. Okay, very weak structure. This is long junctional epithelium. So then they did a research for connective tissue cells. Okay, so connective tissue cells will take 21 days.
So we have to recall patient after 21 days to
That's
check
the
for
reason
any
we are not supposed to
improvement.
probe it before 21 days.
days.
Why? Because if the connective tissue has formed means we won't damage the epithelium. Okay. So if the connective tissue cells, after any surgical procedure, if the connective tissue cells come into the picture, what will happen? Connective tissue adhesion and root resorption will take place. Okay, this and one more is if the alveolar bone cells, these cells come into the picture here, what will happen? Root resorption and ankylosis will take place. Okay, after any surgical procedure. These three different types of repair. Okay, after you do flap surgery, okay, so this might take place, this might take place, or this might take place. These are the different types of repairs.
Here also root resorption and here also.
Yes, along with the connective tissue adhesion
Tissue
here.
adhesion, okay.
Bone is intact. Here bone ankylosis will be there.
Ankylosis.
Okay, because of the bone ankylosis, like resorption, root resorption will take place. Here, because of
But the
this
tooth will not become mobile.
No. Okay, so just like adhesion, if you doesn't treat well, no, so it will be like these are the different types of repair. Most commonly we come across with this long junctional epithelium after any surgical procedure. So then they tried with PDL cells. Okay, so that time they understood if the PDL cells comes into the picture, then we'll get new connective tissue attachment. That is new attachment. These are reattachment. This is new attachment. New cells are coming into the picture and forming the connective tissue. This is called as regeneration. Always what we want is this regeneration, but we won't get it. Very rarely we'll get this. Okay. Because of this, they started with GTR concept, guided tissue regeneration. Okay. Because what will happen after we do the surgical treatment, we have opened a flap, we have placed the graft material, everything. So what will happen? We'll close the flap. If this epithelial cells may migrate, or connective tissue cells may migrate into the picture, or this alveolar bone cells may migrate. So to avoid this, what we'll do is like we'll create a barrier between here. Okay, so that it will guide the tissue when to come, when not to come into the picture. So it will make the periodontal cells to come into the picture. So then only regeneration will take place. Then that is the called as GTR, guided tissue regeneration, guided bone regeneration, GBR and GTR. Okay. Again in that we have one is resorbable one and one is non-resorbable one. Non-resorbable one we stopped using it because for that again we have to do surgical thing. Again we have to open the tissue and we have to remove that. So nowadays we are using normal resorbable one. So the purpose of pocket therapy is now to eliminate pathological changes in the pocket walls and to create stable, easily maintainable state, and if possible to promote periodontal regeneration. That's the reason always we tell if possible. It's not compulsory we'll get regeneration. Okay. And to fulfill these object or techniques, because like when we do non-surgical thing, it's like a closed procedure. We won't be able to see directly. Correct. So calculus, whatever how much we can see at the like supragingival or subgingival, we'll do that. So below our eye level, if it is there, we won't be able to do in non-surgical therapy. To increase the accessibility to the root surface, see our main agenda in like both flap therapy and non-surgical therapy is to remove the plaque and calculus. That is the main culprit in the period. Okay. So increase the accessibility to the root surface, making it possible to remove all the irritants from the root surface, reduce or eliminate pocket depth, making it possible for the patient to maintain the root surface free of plaque, and also to reshape soft and hard tissues to attain a harmonious topography. Okay. That's all, like two techniques, surgical therapy or non-surgical therapy. So if from 2.9 plus or minus like 0.4 mm, we like do the SRP. If it is like actually before it was 4.9, now the concept has changed to 5.1. Okay. Non-surgical therapy for surgical therapy more than 5 mm. It's 5.1. Before it was 4.9 critical probing depth. Now it is 5.1. So we'll commonly take it as 5. Okay. What are the indications for periodontal flap surgeries? Areas with irregular bony contours, deep craters and other defects, deep subgingival deposits, calculus inaccessible for root planing in molar and premolar areas, and sometimes furcation involvement also, intra-bony pockets on distal areas of last molars, frequently complicated by mucogingival problems, are usually unresponsive to the non-surgical methods. And persistent inflammation in the areas with moderate to deep pocket may require surgical approach. Persistent inflammation even after non-surgical treatment. Okay. So starting में like researchers they were like started with gingivectomy procedure. Gingivectomy is nothing but chopping the gingiva. So what they used to do is like
in the ground length.
So before what they used to do is like they used to measure the pocket depth. From the base of the pocket, they used to chop the gingiva and throw it.
Okay. So
like elimination of the pocket. Like that they were doing before. So now the concept has changed. Now we are not using gingivectomy procedures for pocket elimination. Okay. See. Just like by using a pocket marker, just mark the base of the pocket and cut it. Like no gingiva, no pocket. This is the base of the this thing, no, junctional epithelium. From there they are cut. So again we have different classification for flaps. One is depending upon the bone exposure after flap deflection. You know any? You are asking for full thickness, no?
Yes.
That comes here. Okay. Which is what?
This is full.
Okay, this is full thickness and this is partial thickness you are telling. What is the difference between full thickness and partial thickness?
Full thickness, we remove the connective tissue also. The whole
See,
thickness.
that's the reason. Bone exposure after flap reflection. If little amount of connective tissue is left out here, can you see this is the epithelium, this is the connective tissue, this is the connective tissue above the bone. Okay,
So
this
it's a
is partial thickness. Can you see here? Bone is exposed.
Yes, it's a full thickness.
This is full thickness. You are supposed to like either you are doing this or this, depending upon the procedure. Then one more is placement of the flap after surgery. Either non-displaced flap means like where it was there before doing surgery, you would keep there only. Or else you are displacing the flap, either apical to the CEJ or coronal to the CEJ, like that. Either apically placed or coronally placed or laterally placed. This mucogingival surgeries and all will do this. Okay, normal flaps and all we won't do this. Okay, then management of the papilla, whether to conserve the papilla or conventional technique. This type of surgeries will be helpful for the regenerative technique.
ಎಸ್ಮೋನಿಕಾ ಕರಿತೀನಿ ಇಬ್ರು ಕುಡೀರಿ ಅಲ್ಲಿ ಇಡ್ಲಾ
ಇಲ್ಲ
ಹಾ
ಒಂದು 5 minutes ಬರಲಾ
ಆ ಕಡೆ ಬರ್ತೀರಾ
These are the basic classification what we perform for the flap surgery. Coming to the incisions, this is very important. Okay, we have like horizontal incision and vertical incisions, right? So in horizontal incisions, again we have three different incision. One is internal bevel incision, one is clavicular incision, one is interdental incision. Okay, other than this we have one more incision. I told you in like minor surgery, external bevel incision. Okay, so we will give the incision outside the gum till we hit the tooth. Okay, from the outside. That's why it is called as external in the 45-degree angulation. Okay, this is internal bevel incision. Why? Because first they are like researched with the external bevel, then they have come up with internal bevel, and it is also called as reverse bevel incision. Internal bevel incision for flap retraction to expose the underlying bone and root. It can be done by using 15 number blade or 15C surgical blade. Okay, this is also called as fast incision or reverse bevel incision. Okay, because its bevel is in reverse direction from that of the gingival incision, that is external bevel incision. And objectives for this is removes the pocket lining and conserves the relatively uninvolved outer surface of the gingiva, and also produces sharp, thin flap margin for adaptation to the bone and tooth junction. Okay, actually this incision is very good if you are good at it. Only disadvantage is this.
It's a difficult.
No, one is difficult, but you have like once you learn, no, it's good. But only thing is like we have to sacrifice 1 mm of gingiva in this. That is not acceptable.
Like here the
Yes. See, this is the gingival margin, correct? So in this what we'll do is, this is the margin of the gingiva. 0.5 to 1 mm gingiva will leave. Okay, below that we'll give incision from outside until we go and hit the bone. Can you see here? See here. See, this is the margin of the gingiva. But our incision is second line. Can you see this?
Yes.
We are going and hitting till we get the bone. Okay. Internally we are going. So this much tissue is gone. Okay. Recession will already, like after doing surgical thing, we'll get minute recession.
But the collagen fibers they contract.
That retraction will be there. No, so contraction of that, because of that already we'll get one is like 1 mm of bone resorption and 1 mm of tissue contraction. Along with that, if we sacrifice 0.5 to 1 mm of gingiva, then too much of recession will be obviously looking. So patient don't accept that. Okay. In molars and all, you can go ahead with this procedure, but anteriors aesthetically, so you are not supposed to use this. So next is the margin of the gingiva. This is sulcus. So we are supposed to leave 0.5 to 1 mm of the gingiva, and we are supposed to give incision till the bone. Next is clavicular incision. This is second incision we made from the base of the pocket to the crest of the
bone. That we give in the implant. So then we reflect the flap.
yes. It will be in the sulcus.
Sulcus.
Okay, directly we place in the sulcus. Okay, so it will be done by using 12 number blade. Okay, because that beak will be like this. No, it will be easy to go in the interdental areas. So this is the best and most commonly used incision. That's why everyone will use for like implant placement also, any like this thing extraction also they can use this. Okay, if you learn this is enough. We practice this only. We won't go ahead with that internal bevel incisions and all until unless it is indicated. Okay, then first and second incision. So this was the second incision, right? This was the first incision. Can you see this? See. First incision was second line. Now we are giving in the sulcus. We are placing
So
directly.
we will take out that tissue.
Yes. So till we go to the base of the junctional epithelium, we have to go, and we should hit the bone. So from this side also we have hit the bone. From this side also we have hit the bone. This triangular space of like shape of tissue is left out now. Okay, that gives a V-shaped wedge that ends at or near at the crest of the bone. Okay, what this tissue contains? Most of the inflamed and granulomatous area that constitute lateral wall of the pocket and junctional epithelium and the connective tissue fibers that still persist between the bottom of the pocket and the crest of the bone. Here, connective tissue and junctional epithelium both will be present in that wedge shaped tissue. So that we are supposed to remove by using third incision. Okay, see. This is the interdental incision to separate the collar of gingiva that is left around the tooth. By like for this we will use Orban knife. Common like theoretically Orban knife, but practically we can use curettes. Okay, so curette will nicely adapt into the tooth surface. Then we can just remove the tissue. And coming to the, if the vertical incisions are not made, the flap is called envelope flap. Okay, when you give releasing incision, okay, that is not considered as envelope. Envelope is nothing but only one side opening will be there, right? Full envelope. Pocket will be like this, no? Some envelope, so opening will be only one side, correct?
Yes.
So like that only. This flap also, if you are not giving any releasing incision, this flap actually how it will be, okay, like this. If you give releasing incision like this, it is not called as envelope. Without this,
It's envelope.
envelope.
So this internal bevel incision, it's vertical incision.
No. Horizontal incision.
It's horizontal.
Vertical incision is different. Now they have reflected. Can you see the collar of the tissue here? We are supposed to remove this by using curette. You can nicely adopt curette like this and remove that. Vertical incision is
Like this, that will give them the releasing
incisions are nothing but vertical incision or oblique releasing incision. Always it has like few principles. It must extend beyond the mucogingival junction to reach the alveolar mucosa. Okay, always it should extend beyond the mucogingival junction. One thing, and also what happens, allows the flap to be displaced. Then only you can displace the flap.
to expose more area.
No, not like that. One is that. One more is like if you are in the attached gingiva, you can't pull it. Displaced like flaps are nothing but either apical displaced or coronal displaced. For anything, flap should be movable, right? If it is in the attached gingiva, you can't move it. Only alveolar mucosa is like free gingiva, free mucosa. So when you extend beyond that, so this full tissue will be movable. So that time you can retract down also, you can take it up also, or laterally also.
Okay.
Understood? See, so when we are giving, so that's so we give like this, releasing incisions. Okay, just imagine this is mucogingival junction. We are supposed to extend beyond this, and always it should be, base should be broader than vertical. It should be always like this. Okay. Actually, in all cases, we are not supposed to give the incision. Why? Because arteries are like, capillaries, arteries, blood supply will be like this, right? Everywhere. When we give incisions like this, what will happen? It will hamper the blood supply. Okay. So that's the reason we are not supposed to give this releasing incision until unless it's necessary. Okay. And that too anterior, so always we should avoid this. Palatally we can't give. Okay, because palatal tissue is very thick, no? So we can't give palatal. And one more is, see, this is papilla. Okay, so you are always supposed to give not in the center. This is just imagine. This is some distal issue. Okay. Either you are supposed to give here this line angle, or you are supposed to give in this line angle. Mesial line angle or distal line angle of the tooth. You are not supposed to give here in the center. What will happen? You will split the papilla. Okay. You are supposed to give like this. It's incorrect. You are supposed to give line angle, mesial line angle of this or distal line angle of this. Okay. And whether it can be given only one side or it can be given both the sides.
ಇಲ್ಲ ಕರೀತಿದ್ದಾರೆ
ಬಂದೆ
ಕಾಫಿ ಕಾಫಿ ಕುಡಿ
ಡಸ್ಟ್ ಕೊಡು ಡಸ್ಟ್
ಡಸ್ಟ್ಬಿನ್
ಡಸ್ಟ್
ಡಸ್ಟ್
So either vertical incisions at both ends are necessary if the when we need is like if the flap is to be apically displaced or coronally displaced, then only we can apply. If just for the sake of accessibility we are doing it, just imagine, see some last molar is there, okay, so distal pocket is there. So if you keep extending the incision this side, you won't get accessibility in this area, right? So that time what we can do is like we can give a incision, releasing incision here, and we can reflect the flap here so that we can access this area properly. That time only one side is enough. Okay. When you are planning any displacement of the flap, see now it's at the gingiva. Just imagine it's at the CEJ. Now we wanna place this flap either apically, this is apically, or coronally. This is coronal. Then it should be freely movable. So that's why you need both the releasing end should be in both the sides.
So we can suture flap at any.
You are supposed to suture. After you know, so you are supposed to suture like this. This way. Okay.
First the verticals and then the other.
Yes. This is how you are supposed to suture, and here one suture, here one suture, here one suture, here also.
So for the apical displace, we suture a little bit more apical.
This flap will place here, no? This flap will place here. In such case, sutures will come here. And go and come here. So like they have come up with so many techniques. Okay, this is one of the technique, modified Widman flap technique. Hanford and Insta in 1974. And also it is like recognized as the open flap curettage technique. Curettage is nothing but closed procedure, I told. So open flap curettage technique. What we do is like after opening a flap, we'll do curettage for soft tissue also, we'll do root planing for hard tissue also. That's why they call as open flap curettage technique. Okay, so how we do is like, in this technique we'll use all the three incision. The modified Whitman or the internal bevel incision, first incision, second is clavicular incision, third is interdental incision. This is the only technique where we use internal bevel incision. Okay, can you see this? Now left 1 mm of gingiva.
Internal bevel.
Yes. So and they have given incision, internal bevel incision, and they have like after the first incision they have given clavicular incision. Then after the clavicular incision, they have reflected this. Then what they got is tissue tag. The triangular space tissue I told, no? After giving first incision and second incision, see, this was the first incision, right? Okay, this is how they'll give. Then this is the second incision. Okay, this is the third incision. What this tissue? That was the tissue. It's visible in that. See, this is how.
That we remove with the curette.
Yes. See, can you see this? This will be like usually you should remove by using organ style, but by using curette also you can remove that. After that, your job starts. Okay, you are supposed to this they are given by using curettes. They are also removed by using curettes. So after removing that, you are supposed to do root planing of the tooth. Okay, root surface ka root planing you are supposed to do it. Then if any tissue tag is present on the gingiva, you are supposed to trim that tissue. But when you are doing modified Whitman flap and you are giving internal bevel incision, what will happen is tissue become very thin. No need of doing. See, when we are doing like this, no? So we'll remove this
Automatically
layer.
we remove
Yes. Elimination of the epithelial lining. We'll do that. So what will happen? No need of trimming the tissue. If we are not using the internal bevel incision, then we are supposed to trim the tissue when we reflect the flap. After curating everything, so you are supposed to check for any bony defect. Okay, so if any bony defect is present, then you can plan for bone grafting or like some soft tissue regeneration technique by using PRF, GTR, bone grafting, any type of regeneration technique you can use. If no defect, that time after doing a root planing, after tooth surface, then irrigation properly in that area. Not a single calculus should be present. Okay. After that, you are supposed to suture it. That's it. The main advantage of the modified Whitman flap technique is, according to them, is the possibility of obtaining a close adaptation of the soft tissue to the root surface. Why? Because it's very thin. Layer has gone. Correct. Sharp edges will be there. So it will adapt nicely to the root surface. And the minimum of the trauma to which the alveolar bone and soft tissue connective tissues are exposed. Now coming to the modified flap operation. That was modified Whitman. Okay, this is modified flap. You forget this, you can tell it as Kirkland flap. This is the basic and commonly used technique for flap surgeries. What we commonly practice during our clinical practice. Okay, this if you learn, it's enough. So in this, what we'll do is, instead of giving first incision, internal bevel incision, directly we'll go ahead with the clavicular incision. That's what you gave for implant. Okay, in the sulcus, we are supposed to place the 12 number blade till you, from the base of the junctional epithelium till you hit the bone, you are supposed to give incision all through the tooth surface, even in the interdental also. After that, by using periosteal elevator, you are supposed to deflect the flap. then you are supposed to do curettage after. Here in this flap we are supposed to trim the flap. Here we are supposed to do root planing for the root surface, and excess tissue will be there on the flap, no, that we are supposed to trim by using Castro-Viso scissors.
Some different kind of
Ophthalmic scissors. It will be like this, no, very small one. It will be like very easy and curved. It will be.
the curves.
That one more is curved. One more scissor is there.
Okay, that we use here is
It's also called as ophthalmic scissors or Castro. See, because of that, can you see like this? So flap will be like this. Okay, curve will be there. So excess, when you place like this, excess tissue will be inside this. So you can cut that only excess tissue. Because of the curvature, only excess tissue will be get adopted in that. So after that, you are supposed to suture it. That's it. Okay, it's very easy to perform also, very comfortable also. So here what will happen is extensive sacrifice of non-inflamed tissue. So when after you reflect, what will you do? You cut, correct? So what time while cutting, you may cut more, you may cut less, correct? Sometimes if you cut more, that is the thing, we are sacrificing non-inflamed tissue also. Healthy tissue also we may end up in cutting that. Extensive sacrifice of non-inflamed tissues. Apical displacement of the gingival margin. Here we come across with the gingival recession after flap surgeries. Okay. And root surface non-exposed aesthetic reasons, it should be like useful in anterior regions of the dentition, because if we are using modified Widman, anterior region recession will be there. So that's the reason we can use this procedure for anterior regions, and potential for bone regeneration in intrabony defects.
so
Like
for
what?
anterior region it is indicated.
Yes.
Gland.
Only thing is that we do actually for all the tooth. All the tooth, I use this only. Most of the periodontists use this only. Only when we use that internal bevel incision is actually it is good. We'll remove the epithelial lining in a single shot. Okay. In this we may miss out also. Correct? But the thing is, because of recession we won't perform that. Okay. Because a patient may not accept that. 1 mm also matters a lot. Correct? So we are like sacrificing 1 mm after the surgery. If the gingival recession is 1 mm or 2 mm, then it will be like we are only creating a recession. Along with pocket elimination, we are creating recession. Correct? So that's the reason we stop using that. When you have a case for compound crown lengthening, that means like you want crown lengthening procedure. Okay, that can't be done directly by using gingivectomy procedure. You want to reduce the bone height. So that I told you, if you remember. So in such cases, you want like gingivectomy first, correct? So by using that technique, internal bevel incision, just imagine you want 2 mm of gingivectomy. Okay? Still you want to reduce the bone also. It's a compound crown lengthening. That means you are doing gingivectomy also, osseous reduction also. That time, by using this internal bevel incision, you cut off the gingiva. Okay? From the margin, you leave 1 or 1.5 mm, cut it off. Okay? Then you reflect a flap. So gingivectomy is done. Directly you can go ahead with bone reduction. Okay? Or else what you are supposed to do is like with the normal flap only, normal gingiva, directly you can do the gingivectomy procedure by using external bevel gingivectomy. Correct?
We cut
After giving external bevel gingiva, this thing, again you give clavicular incision, then open a flap, then reduce the bone. Instead of that, you can use this internal bevel incision as a first incision. In that, how much or gingiva you want to cut it off, cut it off. Okay. So what happens? The flap also becomes very thin and sharp edge for the adaptation. Nicely. Then you'll get nice contour. Both your indications are succeeded there. One is gingivectomy, and you got like nice adaptation and curvature also will be followed. So the importance of
Then where do we use mostly external bevel incision?
gingivectomy.
Ectomy.
Only gingivectomy. Any like ectomies.
Ectomy.
So this technique will be used like elimination of periodontal pockets to increase the width of attached gingival. Then crown lengthening for prosthetic procedure. This is what I know. Okay, when you are planning for compound crown lengthening, you can use this also or that also. Both can be used.
Like it was 4 mm for the 3 mm for the subgingival margins.
That one, that concept.
4 mm, 3 mm.
Yes. From the like if you are giving equigingival, then it should be the crown margin should be 4 mm away from the
Bone.
alveolar bone. If you are giving subgingivally, minimum of 3 mm it should be. Okay. In such cases, if you think that you are violating the biological limit, then you are supposed to go ahead with compound crown lengthening. That is, along with the gingivectomy, you are supposed to do the ostectomy also. Okay, both soft tissue reduction and hard tissue reduction. That is called as compound. Multiple entity are there. Okay. See, here they have given vertical incision.
This is osseous refractor.
Yes, ashes reconstruction. After reflecting the flap, I can do that. This is how after vertical incision you are supposed to suture it.
Now, if there is a recession after flap surgery, then how do we cover it?
You can't cover it. You can't cover it.
So many soft tissue grafts.
1 mm, 2 mm and all, like you can't do surgical things. For that we have to take graft from the palatal area. Okay. To gain something, we have to lose something. So instead of losing teeth in future, 1 mm of like 2 mm gingiva, this thing can be sacrificed. So that's the reason in perio always like 1 mm of gingiva is the issue. After that, you can give perio pack. See, this is like apically position flap I was telling, no? See, patient have come to you like this. So directly you can, like some clinicians will tell like we'll go ahead with the extraction. Okay? No tooth structure. So if you know like it can be, see if patient doesn't want to go for extraction, you should have like second option, right? So first you are supposed to see the like this thing you have to do, transgingival probing you are supposed to do it. Biological width you are supposed to check it.
At least 3-4 mm of the crown should be there.
Yes.
Before crown length.
Yes, that is like 1:1 ratio at least. You should manage. So now it's not there, correct? So that time what you can do is like you can do the, see they have done gingivectomy here. Can you see here? They have given external bevel here. External gingivectomy they have given. Then by using circular incision they have reflected the flap. After gingivectomy, this much crown was visible.
So there is it's a papilla preservation.
No, this is not a papilla. Okay. So after this, they have reflected the flap. Can you see this? They have maintained papilla very well. You are supposed to maintain like this. If you doesn't give incision properly, you may chop this papilla, then aesthetic gone. The shape should be always scalloped and knife edge. Okay. See, afterwards, what they are doing is they are reducing the bone height here. See. Then you can make out there they have a can you see here and here little bit difference, right? Correct. So what they have done is they have placed little bit apical than this. See, because they have reduced the bone, right? So they are, instead of placing here, they are little bit reduced, like placed apically and sutured it. Okay. Then periopack. This is after a week. Maximum crown structure is there now. They can aram se do post and core also. Various processes. As before like this. Proper processes. So conventional flap. After you reflect. So see here, can you see the bone defect? Bone should be like this, correct? This defect is like this. If you feel, after reflecting the flap, if you feel any defect like this around the tooth, then only you can place a graft. In X-ray what will happen? Either it will look techniques, correct? This is the usual bony architecture. Okay. So what happens in some cases, it will become flat. Okay. So that time you can't do any regenerative techniques. In X-ray you can make out it's horizontal defect or vertical defect. In some cases it will be like this. Okay, it will be like this. Okay. In X-ray it's looking like this, vertical. Some chances are there you can plan for regeneration, but it's not confirmed until unless you open a flap. Do you have any idea like about bone defects?
Maybe the craters.
So actually, that you should actually so many classifications are there for bone defect. See here, tooth is there. Tooth is surrounded from the bone, from all the sides, right? One wall, two wall, three wall, and four. Or like tooth is surrounded by four walls of the bone. Understood? From everywhere it's covered by bone. This is for single. If it are multi-rooted, interradicular also it will be this thing root also bone will be present. Correct? Here also bone will be present. Here also, and other side also bone will be present. So we have one walled defect, two walled defect, three walled defect. Some are combined defects. So what in three walled defect, what will happen? Three walled. Don't get confused. Three walled means three wall are present. Okay. So only one wall is absent. Three walled. That means three wall is present. In such cases, if you put graft over here, so obviously it will take up. Understood? Because something is there to hold the graft. As you saw here. Can you see? If you place here, other walls are there to hold that. Okay? If it is two wall defect, also sometimes grafting can be done because this much is there. If it is one wall defect, all the three walls gone, only one is there. If you place graft also, how it will take? It doesn't take. So in such cases, you can't do any regenerative technique. Only what you can do is like you can open a flap, do the debridement properly, thoroughly with the saline irrigation or betadine irrigation, then place it back.
And we can use the PRF.
That can be used. But the thing is, in to place a PRF also no defect is there. Correct? So where will you place here? Something should be there to hold that.
Hold it.
If you place it, it's like some soft tissue or like putting it below the flap. Okay. If at all it's like any 2-walled or 3-walled defect, that time either you can put a graft mixed with the PRF, or else sometimes I told you in like 2-walled defect also you can as a defect filler. PRF doesn't give rise to a regeneration. It's like only it will release the growth factors. Okay. By releasing the growth factors, it will help in the healing fast. Okay. So then along with that, what we do is like we'll place GTR here.
Okay, there are two wall defect.
Okay. 2-walled or 3-walled defect is there. Then what we can do is like by placing graft, either mixed with PRF or only bone graft. After that, we are supposed to place this GTR here. Here it above this flap will come. So it will avoid the flap to come in this place to form the long junctional epithelium or connective tissue attachment. Okay. So that this will give a stability for the bone graft also, and also guide the tissue for the regeneration purpose. Okay. And other than these osseous defects, they have craters, bore to moat, trench, so many defects. See here. This is like either mesial or distal, just proximal area. Here also sometimes bony architecture will be changed. Okay, interdentally, proximal. Understood?
Mesial or distal.
Mesial or distal, proximally. So if you feel any crater, trench, moat, boat, something is there in this area also, you can do the grafting procedures. Okay, gutter also. Okay, gutter also will, I have that photos, I'll show you how it looks. In some cases you can plan for grafting.
So GTR indication is 3-walled or 2-walled?
Both.
Both.
See, in like 2-walled also, in not all the categories we can't do it. How much bone support is there in the other 2 walls, we are supposed to see it. Very thin, very thick. So we are supposed to see the bone like quality and quantity of the other 2 wall. And most of the times we get combined wall defect. At base, we might be having 3 wall. Okay. As it goes up, might be covering by 2 wall. In such cases also, it can be done. Can you see this? 3 bony walls. This is a tooth. Can you see here how it look? Okay. So 2 wall defect. Other 2 walls are fine. Only this wall is not there. Upper wall is not there. Okay. In such cases also it can be done. This is only 1 wall. See, now if you place any graft material, through and through it is correct. No stability for the graft. So to like go ahead with the regeneration, the graft material should stay in a place for certain period of time. Okay, we can't stabilize that. In such cases, it's of no use doing any regeneration. This is combined morphous defect. Can you see? Little bit is there here. Here 3 wall. Upper, as it comes up, it has become 2 wall defect. In such cases also, it can be done. This is the usual architecture. Okay, so osseous bone recontouring or resective osseous surgery is nothing but when you open a flap, see we have different, as we told, these different types of osseous defects are there. Okay, if any defect is there, like 2 wall, 3 wall, we can go ahead with regenerative technique. If we can't do it, so we have positive architecture, negative architecture, correct? Usually this is the buccal or limbal something. Okay, so this is papillary area, interdental area. It should be like this, bone will be like this. Always soft tissue follows the hard tissue. This is how the gingiva also will be, right?
Yes.
Correct? So due to the periodontal inflammation from gingiva to the bone, what will happen? See, this becomes like this. Can you see? So opposite, false architecture. This is a positive architecture. Can you see? It should be like this. It has become ulta. It should be like this. It has become ulta. Like this. This is negative architecture. If you feel any discrepancies like this, instead of like this, if it is like this, you are supposed, because if it is like this, what will happen? Always soft tissue follows the hard tissue. The contour also becomes like that. That's the reason after inflammation you can see the blunt edge. See? Triangular spaces will be seen in between the molars here. Correct? It becomes like this. So, tissue also go and adopt here after surgery. Okay? Before surgery, pseudo pocket will be there. That means like pseudo attachment will be there. After we do the surgery, what will happen? Reattachment will take place, and what will happen? This tissue and goes and follows this contour. Then this triangular black triangle will be formed here. Understood? So to avoid this, what we are supposed to do is, when we reflect a flap, if we see any negative architecture, so we are supposed to correct this. Okay? Usually, buccally it should be like this, interdentally it should be like this. Like this, like this. Okay? So, if it is ulta like this, see, we can't make it positive architecture in all the tooth. If we are going to do this means, we may end up losing the bone because we are doing a ostectomy there. Correct? So that time what we are supposed to do is at least flat architecture we should make it. We are not getting positive architecture. If you think that by doing this we are losing the lot of amount of bone, then at least we should get flat architecture. Okay. So after opening a flap, you are supposed to see for how is the bony architecture. Any defect is present. If defect is present, you are supposed to do the grafting. If any defect is not there, then you are supposed to do change in the osseous contour. Okay. How will you do? But first what you will do is like, you will give bruise. Okay. On the bone. Okay. Then actually only thing is like, if only in the marginal bone discrepancy is there, only you can do that. But buccally also it should follow that. That time you will give vertical groove. How we give for like crown cutting. See, for the like in the crown portion we'll give some 3 lines like this. Then we'll merge it. Correct? Then we merge like this. So equally we'll like make it a plain structure.
So this we can do when there are no 2 or 3 or defects.
Yes.
The
No, only any change in the architecture, and when the patient comes to you with the extraosseous, like hereditary, like fibromatosis, in such cases what will happen? Enlargement of the bone takes place. Not because of tissue enlargement, I was telling false enlargement is nothing but due to the extraosseous, some tori is there. Okay, in such cases you are supposed to go ahead with osseous recontouring. Okay, and that day you saw some case I was doing. They wanted like because it was like gummy smile or something, so they wanted me to take a bone to the height. Okay, in that also I did osseous recontouring. Okay. In aesthetic consideration, any like crown prosthetic purpose or any like enlargement cases, any improper bony contours, okay, and bony spicules also will be there sometimes. Correct? After extractions and all, bony spicules also will be there. That is also called as resective osseous surgery. See here, you can make out this architecture here. In predominantly inflamed cases, it will be ulta. Here it will be like this or this.
So like here, if they are like combining negative architect also and with the bone wall defects like 3 wall, 2 wall.
Yes, definitely. After grafting here, see, after you graft here,
then we do the recontour.
yes. First what you are supposed to do is like you are supposed to recontour it.
Recontour.
Then according to the height of that, you can put the graft.
Graft.
So see now here, can you see here is the flat. Here it is maintained almost. Okay. So if you want to like correct this, what you'll do is like you'll take it like this little bit.
First we do the recontouring and then we do the grafting.
Then graft. See, after grafting, if you do recontouring, while recontouring you are supposed to put a saline.
Yes, then it will
Wash out, one thing. And one more thing is like, you won't be knowing how much to fill it. Correct? After filling, if you reduce little more, waste of the graft. It costs you more. Correct? So material management also matters. See. In such cases, aram se all the other 3 walls are there. Correct? We can do grafting.
graft.
They have placed a graft material inside.
Here also we use the putty graft. That we
Yes, we can use. No worries. Again, we have different types of graft materials. That is a bit costly. where like grafting can be done when there is a periodontal disease. Okay. So conventional procedures like scaling, root planing are highly effective at repairing disease related defects and halting the progression of the periodontitis. Okay, here we are not going to regenerate by doing scaling, root planing, non-surgical. However, they do relatively little to promote regeneration of the last periodontal support structure. Very little effort from their side. Okay, when we do non-surgical treatment, little effort will be there to get the regeneration of the periodontal last support. So bone grafting is the most common form of regenerative therapy. Okay, only treatment that leads to the regeneration of bone, cementum and functionally oriented new PDL coronal to the base of the previous osseous defects.
So it is possible with a guided tissue regeneration.
So we
When
have
put
different
the bone graft, then also we have to put that membrane.
the GTM
As a result, resolvable
yes, yes. I'll show you that. So now coming to the classifications, if the graft is procured from the same individual, that is called as autograft. Autograft. So again in autograft we have different like procurement areas, extraoral and intraoral. Extraoral will be iliac crest, tibia, fibula, ribs, intraorally chin, extrortosis and torus, ramus, tuberosity. So these are the few areas from where we can take a autograft. See, when like you have like one patient comes to you with a pocket is there somewhere, and the same patient has a third molar extraction or something. So obviously, if it is a disimpaction case, you are supposed to trim the bone, right? So you can lose that, like created that bone graft. Okay, that whatever the bone will trim, no, in the third molar area, that we can collect and keep it. Okay, and we can use the same bone particles as a graft in the other periodontally infected site. Okay, see this chin, extrortosis, torus, ramus, tuberosity, these are like second surgical site. Patient may not agree for that. If they agree, fine. See, extrortosis I was telling. Only like ostectomy and recontouring has to be done. In such cases, while doing that, you can collect the granules of the bones.
Then we
Okay.
have to
Yes.
crush.
No, sometimes you may trim it. If you are trimming, you will take the powder. If you are taking in the like by using ronger and all, you can take a piece like that. Okay, so that you can like again we have like mix it with the saline, mix it with the blood coagulum and all, make it that for that we should have separate instrument also. Okay, this anyway patient doesn't agree for all these things. Okay, then coming to the genetically identical donors, that is like isograft, twins may. And one more is from the same species, is nothing but like from the humans only, that is called as allograft. First they started with fresh frozen, next they have come up with FDBA, next DFDBA. This is demineralized, fried, what will do is like in bone, so many layers will be there. So in this what they did is, they have removed all the minerals. So that time they exposed the BMP. BMP, you know, bone morphogenic protein. Okay, that helps in the formation of the bone. So first they started with all those things, then they realized that, so if we are using like mineralized bone graft, so that may be like halting the regeneration. So they come up with this demineralized. They demineralized nothing but they removed all the minerals from the graft. So that time that BMP was exposed. So when we use that kind of graft material for a grafting, so due to the presence of BMP, exposed BMP, it will initiate the other bone cells to form the bone. Okay, so nowadays we commonly use this one. You remember this DFDBA. Okay, next coming is synthetic one, that is called as alloplast, hydroxyapatite, like CPC, and one more is, this is also we commonly use, bioactive glass. Okay, synthetic polymers, biphasic alloplast materials. These are the few alloplast what we can use. These are the defect fillers. Why? Hey, next Friday you are coming. You are going.
Friday, no?
One ಇದು ರಿಆರ್ಸಿ ಕೇಸ್ ಇದೆ, ಅದು ಘಟ್ಟಪರ್ಜಕ್ಕೆ ಬರ್ತಾನೆ ಇಲ್ಲ, ನಾನು ಟ್ರೈ ಮಾಡ್ತೀನಿ, ಬರ್ತಾ ಇಲ್ಲ, ಇಷ್ಟೇ ಇದೆ.
ಬುಕ್ಸ್ ಏನು ಮಾಡಿದ್ದಾರೆ ಡಿಂಟ್ ನೋ ಐ ಥಿಂಕ್ ಅದು RC ಕೇಸ್ ಅಂತ RC ಅಂತ ಬರೆದಿದ್ದಾರೆ. ಎಕ್ಸ್ರೇ ತೆಗೆದ್ಬಿಟ್ಟು RC ನೋಡೋಕ್ಕೆ ಅಂತಂದರೆ ಲೆಕ್ಕ ಎಷ್ಟಿದೆ. ಅದೇ ಅಜ್ಜ ಅವತ್ತು ಲ್ಯಾಟ್ರಲ್ ಕೆನಲ್ ಕ್ಯಾಲ್ಸಿಫೈಡ್ ಆಗಿತ್ತು ಅಂತ ಎಕ್ಸ್ಟ್ರಾಕ್ಟ್ ಮಾಡಿಸಿದ್ವಲ್ಲ, ಸೇಮ್ ಫಿಲಮ್ ದಟ್ ಪ್ರಿಮೋಲ್ ಆಲ್ಸೋ ಲುಕಿಂಗ್ ಲೈಕ್ ಕ್ಯಾಲ್ಸಿಫೈಡ್. ಹೌ ಟು ನೆಗೋಷಿಯೇಟ್ ಆಯಿತು. We told the patient like maybe Tuesday sir may come on. Tuesday will be sir. Chalo bye, see you. I don't think so we'll meet again.
Yeah.
Chalo, okay, all the best. I think for sir. Sorry, okay, bye bye.
The petty graph house under Alpla.
Yes. So that is like bit costly actually. Novabone you are telling, no? That injectable one.
Injectable.
So actually it cost you around 7,000 or something. Patient should be able to like afford it. This comes around some 4,900 or something. In that we can graft around say 3-4 defects. ಹಲೋ ಹೇಳಿ ಮೇಡಮ್, ಯಾಕೋ ಫೋನ್ ಮಾಡಿದ್ವಲ್ಲ ಅಂತ ಅನ್ಕೊತಾ ಇದ್ದೆ. ಕರೀರಿ ನಾನು 7 ಕರೆದು ಬರ್ತಾರೆ ಅಂದರೆ ಕನ್ಫರ್ಮ್ ಮಾಡಿ ಹೇಳಿ. ನನ್ನ ಮಗಳೂ ಕರ್ಕೊಂಬರ್ಬೇಕು ಕ್ಲಿನಿಕ್ಕಿಗೆ. ಅದಕ್ಕೆ ಇಲ್ಲಪ್ಪ ನಮ್ಮ ಹಸ್ಬೆಂಡ್ ಊರಿಗೆ ಹೋಗ್ತಾ ಇದ್ದಾರೆ, ಮನೇಲಿ ಯಾರು ಇರಲ್ವಲ್ಲ, ಅದಕ್ಕೆ ನಾನು ಕನ್ಫರ್ಮ್ ಮಾಡಿ ಹೇಳಿ. ಓಕೆ. ಇವ್ರು ಮಂಜುನಾಥ್ ಅವ್ರು ಆಗಲ್ಲ ಅಂದ್ರಲ್ಲ 11ಗೆ. ಹುಡುಗಿ ಕರೀರಿ ಫಸ್ಟು, ಅವ್ರು ಪೇಮೆಂಟ್ ಮಾಡೋದಿದೆ. ಅಂಜಿ ಓಕೆಪ್ಪ, ಸಿ ಯು. So next is like from the different species, it's called as xenophile. Either like procured from like bovine procrine, coralline, calcium carbonate. So actually when you are using xenophile, ethical issues comes. Okay, you should inform the patient. Okay, some religion people may not go for bovine, some people may not go for procrine. Correct? You might be like knowing that. Hindus doesn't go ahead with the bovine because like it's like from the ox. Procrine is nothing but from the pig. Muslims may not go for that.
Echoing from the horse.
So that's the reason like some ethical issues may come. So if patients are ready, we don't mind. It's readily available also. We can like around from market we can buy if patients are ready. These are some ceramics and bioactive molecules composite graft has come. It is like newer technologies are coming. Defect fillers, they are coming with new technologies.
So they
What we
also
commonly
convert into bone after some time. These fillers.
Sometimes means
Like after, like when we put it, then it is replaced by bone.
no, that wait, I'll come there. So what we commonly use is DFDA, okay, then allografts. These are the allograft and allografts are commonly used for regeneration. So that whether it will be used or not depending upon this characteristic. Okay, so these are like evaluated on the base of their following properties. Osteogenesis. Usually if it is having osteogenesis property, that means like bone forming property, that means like it is having good effect, that will cause a regeneration. Okay, it provides the stem cell with osteogenic potential which directly lay down the new bone. Okay, this example is this autograft. Our own body cells will start laying down the bone. One more is osteoinduction. It is like induced differentiation of the stem cell into osteogenic cells. How it happens is like when we place some graft material, so it will tell their friends, hey guys, you start laying down the bone, inducing the other people to lay down the bone. Okay. So for example, for that, this is demineralized. So I don't know, BMP will be present in that. That will initiate the other people, okay, to lay down the bone. Okay. If the material is osteoconduction, it is nothing but defect fillers, I was telling. Large amount of defect is there. Okay, when we place osteoconduction property material, what will happen is like it will create an environment so that other bone forming cells come into that place and they'll start laying down the bone. Okay. So provide a
So that's
passive porous scaffold upon which new bone can form. It's creating environment, good environment. Okay, bone forming environment it is creating. So other osteogenic cells should come into that place and they should start laying down the bone. So for that alloplast must be understood. So these are the like few, that's the reason. See, always we can't go ahead with osteogenesis graft. So we can go ahead with this osteoinduction. This is when this also can't be done, then obviously as a defect filler.
Like the
Okay.
ceramic, the
So we can use this material. So depending upon this concept. So what are the ideal characteristics for the bone grafting? It shouldn't be non-toxic, non-antigenic, resistant to the infection, no root resorption, ankylosis should take place, easily adaptable, easy storage, cost effective, readily and sufficiently available. Okay.
no ankylosis should be there.
No. So then like what is the use? No regeneration, no? So if ankylosis will take place means what? It's a repair, not a regeneration. So that's what, no root resorption and ankylosis. It shouldn't initiate that. Then readily and sufficiently available, should be completely replaced by host bone of same quality and quantity. Okay. These are the basic ideal characteristics. Objectives for reduced probing depth, clinical attachment gain, bone fill of osseous defects, regeneration of new bone, cementum and PDL cells. Indication, deep intraosseous defects, support for critical teeth, bone defects in aggressive periodontitis as an aesthetic purpose or focation defects. Advantage is regeneration of attachment apparatus is possible. By reconstructing the periodontium, it is possible to reverse the disease process. Okay. Increased tooth support, improved function, enhanced aesthetics are concomitant results of the successful bone grafting therapy. And application in the intraosseous and furcation defects. What are the disadvantages? Like additional treatment time is required, autograft required, second surgical site, very expensive, chances of reinfection, additional post-care, operative care after bone graft therapy, prolonged healing time, and sometimes multiple therapy required.
So like
This is very
for the connective tissue regeneration takes 21 days. Like for the bone also
minimum,
the
actually minimum 3 months.
3 months. Like the implant.
You can see like bone is like everywhere same only.
3 months.
Okay, minimum is 3 months. You can see the changes after 6 months properly in the radiographic changes. Okay, so factors affecting bone regeneration. That's what when you are doing any regenerative technique, you can't show the results to the patient immediately. You have to wait minimum 3 months sometimes. Okay, after 6 months you can exactly like make out how much is the bone like regeneration has taken place. So what are the factors affecting the bone regeneration? So one is patient selection. See what kind of defect is this? Absence of infection. Root debridement. If you have not done proper root debridement, that means non-surgical treatment you have not done properly. It's going to be failed. Morphology of the defect. If it is one wall defect, if you do it, what is the use? So morphology of the defect. Okay, then particle size. What kind of like graft, like in the defect, which size of like graft material you are taking it. So now no need to worry about that. Already research has been done and they have like given the ready-made grafting materials. So DFD behind osteograft करके it will come. So if you use that,
So you probably use the
osteograft. These people are using like G bone. So I use osteograft.
So it's in a powder form.
So actually started with particle size. Some was telling sizes, different sizes particle will come. So now we won't take our head for all the particle size. What is readily available in the market, we'll take that. And flap refraction and movement stability, condensation of the graft. You should properly pack in the defect area and bone fill.
Like there also the graft rejection can be there, like for the like this foreign
Yes, definitely. That's
alloplast.
all. Absence of infection. Sometimes what happen? See, you have not done any proper root debridement. You have placed it. That means like granulation tissue is present there. Infection is there. So what will happen? You are done like placed a foreign material. Rejection of that, sometimes abscess may take place. Bacteria will be there, no? So bacterial colonization will be more. So that time what will happen? It doesn't take. So abscess formation may take place. That's the
Otherwise,
one.
there is no rejection of graft like in normal patients where there is no granulation. Like,
No, like
but
not
in
rejection.
this-
It may not cause regeneration. Understood? Not rejection means like no infection, but it may not take up.
Take up, yes.
That means like regeneration was not has been taken place. That might happen. It's not very rarely will come across with the infection. We have come across sometimes like abscess will be there, some reinfection will be there, tissue changes we can see. Okay, if patient is not maintaining well after placing graft and all, like we come across definitely. Food impaction is there definitely that time and all. So bone graft will be like exposed. Approximation of the flap is not good. That time also bone graft will be exposed to the oral environment, external environment. That time also rejection will take place. But only like if reinfection, no abscess means nothing like effect to the patient. Only thing is regeneration doesn't take place. How the defect will be like that only. No changes in the defect. Revascularization.
So only repair will be there,
Yes,
but no
repair it is not
regeneration.
space maintenance, graft immobilization, okay, that's all. Graft shouldn't move when you place it, okay, and periodontal dressing. That's the reason after grafting and all we give periopac. And healing time, post-surgical care. These are the factors. Root debridement, you are done, not done properly. Then infection is present. Then also, see.
Like sometimes body's own immune cells they recognize the foreign material,
Yes.
then they start attacking and
Yes.
they
Yes. These are all see, like how we do like by using trifine bursts, bone trap, bone scrapers, suction trap, these surgery. By using these instruments, we can do the autografts. Okay. Graft procurement, how you do is like by using all these
like
things.
this we use in the sinus.
Yes. But like we can't like keep all these things, so that's why we go ahead with the direct grafts.
So like it's like 3-4% rejection,
Sorry.
like the rejection for the bone graft. It will be like in 3-4% cases. Like
You have seen
no, just asking.
rejection so many times it will be there. So many. That's what I would told. No, those are the factors. It will be depending upon the whether like regeneration will takes place or not. What kind of case you have selected, what type of defect you have done, what type of flap you have done, okay, how you have sutured it, how much good debridement you have done. Those are the factors from the doctor's side.
And the medical history of the patient also like has some contribution. Like if the patient has some like autoimmune diseases, like in that case also it can.
No. No. Only like diabetes patients like so they have the tendency for the periodontal abscess. So in such cases like we can come across if patient is not maintained glucose level. So if the glucose level is see every like systemic diseases like have to deal with what like body immune, correct? So body cells has to like support the whatever the treatment we have given. Okay, that's what I'm telling. Rejection is nothing but no regeneration will take place. Okay, so rejection, as you told, if any like body cells are not going ahead with the properly, that time pus formation may take place. Abscess may form there, not more than that. It doesn't like resorb the adjacent bone and all. Okay.
So like then how do we manage those cases like with a proper antibiotic or
What cases?
like these rejection cases?
No, antibiotics course only. Antibiotic course. Very rarely you come across. Okay, that's what. See, if why to like do the complications? You have to follow the proper protocol.
Yes.
You are doing like case selection properly and diagnosing properly. Whether if you do like a grafting procedure, it will be helpful or not. You should analyze that. After doing that, what type of graft is good for this? What type of lab design is good for this? See, this and all like you won't like suddenly by doing 1 or 2 patients you won't come to know. For that you need a full theory backup. Okay. Okay, so that even in 1 or 2 days we can't teach you that, because full theory knowledge cell to cell, whole cells formation, for that what like osteoblast does, osteoblast does, what are the scenario in diabetic patients, how these cells act. For that you should have like basic knowledge of the theory, then only like you can like adopt your theory in a practical. Okay, it's very like perio is nothing but like cellular biology. It's not like RCT or prosto, so that you can like see in front. Everything is at the cellular biology, so everything will be going on. Fibroblast, okay, helps in the collagen fibers formation, PDL cell formation, osteoblast, cementoblast, everything is cellular biology. If you know when those cells changes, when those cells start laying down the bone or PDL fibers or cementum, then you will get a correct picture. What is the condition of the patient? If you do treatment, what may happen? If you doesn't do treatment, what may happen? That's the problem. First is diagnosis, treatment planning, then you should think about prognosis of your treatment, then you should go ahead with the treatment.
So we have to plan very carefully.
Yes, definitely.
From beginning.
Yes. If something goes wrong, diagnosis goes wrong, your treatment plan may end up with something. If you are doing something else treatment plan, what will happen? Prognosis will hampered, correct? Then patient will fire back. So if you are properly diagnosing, see now patient has come, if you feel this is a periodontitis patient, what treatment has to be done, whether surgical or non-surgical? If you feel both are required, first you are supposed to do non-surgical treatment for toppers. So then you are supposed to wait for 1 month. So then you recall the patient, check for the periodontal pocket. If still pocket is persist, then you can plan for surgical. So before doing surgery, you are supposed to take radiographic everything. Then their patients like everything, blood report, bleeding time should be considered, clotting time should be considered, any medical history, any patient is taking any medication, and you are not supposed to do surgical procedure within 6 months of the any cardiac issues. Okay. So then if the diabetic patient is diabetic and his HbA1c range is 9 to 10, then also you are not supposed to test the patient for surgical procedures. Everything you should think about. Then you are supposed to measure the pocket depth. Then you are supposed to see the what kind of tissue is there. Okay, whether spacing is there in between, what kind of flap you are planning, bone exposure, partial thickness or full thickness, okay, any displacements or any papilla preservation, what kind of thickness. Okay, after you reflect it, okay, you are supposed to check for the bony defect. See, that's what I told, by seeing an X-ray you can't make out whether it can be regenerated or not. Once you open a flap,
Then only we see.
after you open a flap also, it's very hard to find out. Once you open a flap, you should see the bone as a white, every surrounding the tooth. No, not even a single or little bit of blood should be there. Then only like by wiping neatly you can make out what kind of defect. Here, again, if you are doing a grafting, whether it will help the patient or not. Okay, if you feel that it is helping, how the patient maintenance is there. If patient is not maintaining, if you do it, then what is the use? And if the bone support of the adjacent tooth are the same root, two rooted teeth, one root you are planning for grafting and one root bone support is not there, then what is the use of that? Everything you are supposed to see it. Okay, it's very complicated. That's what. See, it's not like even we took a lot of time to understand what exactly it is. Very difficult. Once you open also, we will be struggling. What kind of defect is this? What kind of a defect is this? To see that. So after that, see, after if you place a graft also, if you maintain an approximation of the flap. Okay, how you suture it. If your suturing is not good, approximation doesn't happen, takes place. If approximation is not good, so that time your graft rejection takes place. Foot plaque infection will be there. Okay, so due to that, what will happen? And the graft materials also will be exposed to the external environment. Infection will take place. So even in like a diabetic patient also, if it is more this thing, then also you are not supposed to do the surgical procedure only. You forget about rejection. You are not supposed to touch the like surgical procedure.
Only the non-surgical.
Yes. So you should keep all those factors, everything, and your debridement. Your non-surgical procedure is not good enough. Okay, and okay fine. हाँ मैंने तो कर दिया. Okay, अभी open कर दिया flap. You have done a grafting. You have missed some carapace there.
Then it will not work.
Okay, and some granulation tissue there. We have a two concept now, whether like to leave a granulation tissue or not to leave a granulation tissue. Before it was like you are supposed to remove fully. Okay, now concept has changed. See, if any carapace is present somewhere, so again bacterial colonization will take place. Correct, no? So then again rejection of the bone graft. You see here, they have placed the GTR here and they have closed it. So tissue is above the GTR. Can you see here? There they have placed it here. If we can place graft over here, then the new bone formation is taking place.
Very nicely comes.
I'll show you the grafting there. This papilla preservation, no? So in this what we do is like, this is a papilla, right? So one side will give like circular incision from here till here. We won't go in the interdental areas. Okay? Only in this area. And in the this is buccal side. Okay. Other side, this is a palatal side, right? In other side, what you are supposed to do is like we have to give after this. We are supposed to give incision like this.
So
This is papilla.
The papilla is reflected toward the buccal
Other side, yes. See, like this. The papilla, like the tip of the papilla of the one side is will be attached to the other side only. Will reflect to the other side. So this can be done only when there is interdental space. If it is a very tight contact, you can't push the papilla there, correct?
Yes, because it will not come out.
Yes, that's the reason.
So only in case of
Interdental
interdental
space,
we
then
can
only we can.
papilla
Yes.
preservation.
So when we are doing a papilla preservation, what will happen? It will help in a like proper good regeneration of the bone. Hello? हाँ सीमा और है हाँ सीमा है ಹೌದಾ ಅರ್ಜೆಂಟ್ ಇತ್ತಾ ಚೆಕ್ ಅವ್ನು ನಾಳೆ ಬರಲ್ವ ಹಂಗಾದ್ರೆ ಹೌದಾ ಬಂದು ಹೋಗ್ಬಿಟ್ಟಿದ್ರೆ ಅಟ್ಲೀಸ್ಟ್ ಒಂದ್ಸತಿ ನೋಡ್ಬಿಡ್ತಿದ್ವಿ ಬ್ಲೀಡಿಂಗ್ ಎಲ್ಲ ಕಮ್ಮಿ ಆಗಿದೆಯಾ ಓಕೆ ಸ್ಪೈನ್ ಅಲ್ಲ ಇವಾಗ ಸ್ಪೈನ್ ಅಲ್ಲ ಹ್ಞೂ ಅದೇ ನಂಗೆ ಓಕೆ ಓಕೆ ಅದಕ್ಕೆ ನಾನು ಅವ್ರಿಗೆ ಇವ್ರಿಗೆ ಹೇಳಿದ್ದು ಹೌದಾ ಸರಿ ಓಕೆ ಹಂಗಾರೆ ಫೋನ್ ಮಾಡ್ಕೊಂಡು ಬಾ ಸರಿ 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 ಅವ್ರಿಗೆ ಅದೇ ಈಗ ನಾಳೆ ಕರಿತೀನಿ ಅಂದರು ಅವರು ಆಯ್ತು ಕರೀರಿ ಅಂತ ಅಂದೆ ನಾನು ಹಾಂ ಸರಿಯಪ್ಪ ಸಿಮ್ ಕನ್ಫರ್ಮ್ ಮಾಡಿ ಹೇಳ್ತೀನಿ ತಡ್ರಿ ಸರಿ ಸರಿ ಓಕೆ ಸಿಮ್ ಹಾಂ ಸರಿ ಸರಿ ಓಕೆ
So for this flap, there should be some triangular space there between the teeth, this interdental.
ಹಾಂ so like we'll take it to the other side, no? So why like we do the like papular preservation is that see sometime defect will be there here. Can you see here? Yeah. If we are doing this papular preservation, what will happen? This papilla will come and cover the graft area. Stabilization of the graft material takes place. Understood? It doesn't displace so easily because like it's like a cap. A papilla is covering like a cap. It doesn't allow the graft material to dislodge. So in such cases, if we are doing papilla preservation, it is very helpful for the regeneration. Okay, but it can be done only when there is a space between the tooth. Interdental space should be there. Again, we have like different papilla preservation only, modified, simplified. So few people will give incisions like this. Few people what they do is papilla will be like this, no? So few will give incisions like this, okay? Few will give horizontal incision, few will give oblique incision. Modified, simplified and conventional. Okay.
This is modified.
Yes, simplified. So just they have changed little bit according to their like to avoid the like invasiveness and the tissue contour and all. They have changed simply like. Newer advancement will come, no? Like that they have done. Starting they were doing like this. They'll give incision like this and here. This papilla will be gone to the other side. This will be gone. This
This is
go to the other side and there is space will be. Okay. So here if you feel any defect is there, so you can put a graft material here. So we can take this back here and if we suture it, stabilization of the graft material will take place. And one more thing is, when you do any like normal procedures, what will happen? Precision will take place, correct? And always soft tissue follows the hard tissue, I was telling you. So what will happen? This knife edge may become blunt edge.
for the bone.
No, tissue.
For tissue, soft tissue.
Soft tissue. It's a gingiva.
Gingiva.
Okay, so it will like, this is scallop, here it is knife edge, right? So it will become blunt. Okay, so papillary tip will become blunt. But if you are doing this, the shape will be maintained. Because we have not cut, usually what we'll do is like, so other side also it will be like this, right? We'll go, give incision from here and we'll go and cut below this. Give incision and we'll go cut here. So after the surgery, this will become blunt, both the sides. It's not compulsory, most of the times. So all these drawbacks can be avoided in this. to obtain both coronal positioning of the flap and primary closure of the interdental space prior to attempting regeneration of the suprabony component of the defect. This is a here they are doing horizontal incision. Okay. They have sutured it. Here we can use matrices. Can be successfully applied in conjunction with a variety of regenerative materials. Okay, so well, like when we are using biologically active materials, EMD1 material will come. If we are using that, our growth factors or bone replacement graft materials, this technique can be used. Effective in wide interdental spaces more than 2 mm. Okay, large amount of attachment gain and consistent reduction of pocket depth assessment with minimal or no recession reported.
So if it is more than 2 mm, then we can.
Yes, we can flaps. And one more is, this is distomolar surgery. Okay, so when there is a pocket distal to the 7 or 8, okay, that time what you are supposed to do is like, see, either here and all normal circular incision. I was telling you, no, so we can't give accessibility here. So in such cases we can give rinsing incision. I was telling, right? In such cases you wanna eliminate distal pocket, so you can give like the either like this incision. Here one incision, here one incision. Center में whatever the tissue will be there, we'll take it out. Okay. Then see, either you can give instead of triangle also you can give both parallel and one is vertical, and one more is. So H shape we can give instead of here, no, one more we can give like this. Different techniques. Can you see this? They have removed the tissue from this. This is one is horizontal incision, here horizontal, here vertical incision. So whatever the tissue will be present here, we have to pluck it. Then we are supposed to give sutures here.
So that will
Distal
eliminate
is
the
eliminate the
distal
pocket.
side
Even though we are not using some microscope, endoscope and all. See the defect here. Here see, flap only on the buccal side to access the defect and not involve the opposite side. Only like one side they have done. Emerging awareness of periodontal health and more demands of the patients to prevent the loss of teeth, the flap surgery has been emerged greatly in like since 2 decades. Okay, so minimally invasive surgery nowadays we are coming up with the minimally invasive surgeries, microsurgery and all. Okay, by using microscopes and all we can do that. And periodontist should properly study the case in hand and then decide the type of flap design that will provide actually good possible long-term stability. Okay, case selection is very important. In all cases, all kind of techniques you can't use it. Okay, so by seeing that you can give a proper stability of the periodontium as well as give a appropriate aesthetic outcomes. Okay, so what you can perform is like by using clavicular incision, envelope flaps can be performed by you guys. It's a very easy technique and best technique. No complications involved in that.
there we don't have to give the vertical incision, we have just to give the clavicular and reflective.
Even if you wanna give like vertical incision also, no, not a big deal. You can give it. Only thing is you should be good enough to suture it properly. If you are good enough in handling a soft tissue, then definitely you can do it. You are able to like they will give you cases, periodontal surgeries and all they will give you.
No. And lasers are also the part of the non-invasive.
Yes. So only like for ectomies and all we can use gingiviectomies, frenectomies, that and all we can use lasers. If it is a non-invasive, photodynamic therapy I was telling you, that is also considered as non-surgical therapies. By using dye, we'll inject a dye in the sulcus area. So then after some time, we'll pass the laser light. So it will kill the bacteria. But we are not sure what kind of a bacteria is present in our oral cavity, correct? It's a blind procedure. That's the reason always along with SRP you are supposed to do laser disinfection. Alone if you are doing, it's of no use. Anything else doubt you have?
It was a nice lecture.
Is it? Thank you. क्या पापा? ಮತ್ತೆ ಅವ್ನು ಕ್ಲೋಸ್ ಮಾಡ್ಕೊಂಡು ಹೋಗ್ಬಿಟ್ಟಿರಾ ನಾವು ಇಲ್ಲೇ ಇದ್ದೀವಿ ಅಂತ. ಹೌದಾ, ಓಕೆ. Like basic things, gingivectomies and all you can perform, and that crown lengthening procedures also you can do it. Some this by using envelope flap also you can do it. Anyway, you have done or like for implant placement and all, like you have reflected, no? Same thing. Okay. Only thing is you should be good enough to do debridement. Okay. The thing is like vision is very important for periodontist. You should keep looking at the calculus. We should keep searching for the calculus in the oral cavity, that too when we open a flap. You know, like we used to do like, we have done. When our professor used to come and see, there is a calculus, here is a calculus. Like that. Okay, like how much ever you do, no, you should keep searching there. Little bit of plaque or calculus is present, that means like again chances will be more. So if you do proper scaling, half of your job is done. People like get bored of doing scaling, but if you are doing proper subgingival scaling, half of the perio treatment is done. So you are arresting the disease progression up to 6 to 8 months. That is enough now for patient. That's why any perio patients follow. Every 6 months once you do proper subgingival scaling, then definitely you can extend the period of lifetime of the tooth. Anything else if you want? Let me know. That one case in Ramnagar and one case in Chanpatna I have. Ramnagar I don't know whether that patient is agreed or not. Chanpatna maybe that lady, she may agree. I told her so much. Now I need to talk to sir. If patient is ready to come here, we'll do it here. Or else you come with me, we'll go there. Till January 10th you are here, right?
Yes, sir.
How many cases they have told you?
3, 4.
Actually in her, 2 quadrant you can do.
I will go to Chanpatna.
Upper actually a lot of mobility is there. I don't want to spoil actually, because while we reflect and while doing this thing, patient is not ready for extraction. Okay, so only lower I have told her we'll do the surgery. Upper if she wants extraction we'll do, and we'll do replacement. If she doesn't want, after doing non-surgical therapy, let it come for how many years. If you wanna have if you have any doubt, you please let me know. I will tell you. Okay?
Okay.